We are not born with a fully developed skeletal system. Ossification or osteogenesis is the process of bone tissue formation. It's the formation of the bony skeleton which begins in the second month of development. After we're born, there is still some postnatal bone growth. This occurs until early adulthood. And throughout our entire life, we have bone remodeling and repair. So bone development goes on throughout our entire life. There are two types of ossification. Endochondral ossification occurs when the bone forms by replacing hyaline cartilage. The bones are called cartilage or endochondral bones, and this is how most of our skeleton is formed. Then we have intramembranous ossification. Here the bones develop from a fibrous membrane. These bones are called membranous bones. There are a few of our flat bones that develop this way. Endochondral ossification forms most all of the bones inferior to the base of the skull. The exception is the clavicles. This begins late in the second month of development. The bone initially is laid down as hyaline cartilage. Then we have to break down the hyaline cartilage prior to ossification. Endochondral ossification begins at the primary ossification center in the center of the shaft. Blood vessels infiltrate the perichondrium and converts it to a periosteum, and then mesenchymal cells change into osteoblasts. There are 5 main steps in the process of ossification of cartilage bones. First, a bone collar forms around the diaphysis of the cartilage model. The central cartilage in the diaphysis calcifies, and when this happens, this kills the chondrocytes. The periosteal bud invades the cavities. This leads to the formation of spongy bone. The periosteal bud is blood vessels, osteoclasts, and osteoblasts. Because the diaphysis is still made of cartilage, it can elongate, and we begin to hollow out the bone. Those chondrocytes die, and the medullary cavity forms. We then see secondary ossification centers appear in the epiphysis of the bone, and then the epiphyses ossify. Some of the original cartilage remains as articular cartilage. Starting at about week 9, our cartilage precursor bone gets a bony collar around it, and we begin to see the primary ossification center in the center of the bone, the diaphysis. Over time, the chondrocytes deteriorate, and we begin to get the hollowing that's going to be the medullary cavity. Blood vessels invade. This is the periosteal bud, so we're bringing osteoclasts and osteoblasts into this area to begin the formation of bone. At birth, we have a fairly well-developed medullary cavity, and the shaft of the bone, the diaphysis here, is already been remodeled to compact bone. We also have the beginning of those secondary ossification centers in the epiphysis of the bone. Childhood to adolescence, we continue to lay down bone, we continue to remodel the bone, and this cartilage, the epiphyseal plate, continues to be an area where bone growth can occur. Intramembranous ossification is used to form the frontal, parietal, occipital, temporal bones and the clavicles. This begins with a fibrous connective tissue. These membranes are formed by mesenchymal cells, and the mesenchymal cells are still present. Mesenchymal cells can turn into any kind of connective tissue cell. There are 4 major steps in intramembranous ossification. We will have ossification centers form when the mesenchymal cells begin to cluster and become osteoblasts. Now, in one membranous bone, we will have numerous ossification centers occurring. The osteoblasts secrete osteoid. This is then calcified. We get woven bone or spongy bone formed when the osteoid is laid down around blood vessels that are in the membrane. This will give us our trabeculae. The outer layer of woven bone will be reformed into a periosteum, as well as being reformed into lamellar bone or compact bone. Red marrow will then appear in the cavities of the spongy bone. So here is our membranous bone laid down with mesenchymal cells. Some of these differentiate into osteoblasts. They secrete osteoid, and as this calcifies, the cells get trapped in the matrix and become osteocytes and will maintain this matrix. We have this going on in several places in any flat bone. The blood vessels that come in act as ways for that spongy bone to be laid down, and we make the trabeculae and leave the holes, and these blood vessels eventually will deposit the red marrow in this place. The mesenchyme becomes the periosteum. Some of these osteoblasts lay down cancellous bone. Some of the osteoblasts begin to develop compact bone here, so we have our compact bone shell and our spongy bone center. Bone growth occurs after we're born. We have interstitial or longitudinal growth where the bone gets longer, and we have appositional growth. This is an increase in bone thickness. Bones stop growing during adolescence with the exception of some facial bones. The jawbone and the nasal bones can grow slowly throughout life. The interstitial growth or the increase in length occurs because the epiphyseal plate remains cartilage for bone growth. Chondrocytes within the cartilage divide and form new cartilage. This pushes the old cartilage up, increasing the length, and the new cartilage ossifies, becoming new bone. Near the end of adolescence, chondroblasts divide less often, and eventually the epiphyseal plate thins and is completely replaced by bone. Bone growth is then complete. Appositional growth allows the lengthening bone to get wider. Appositional growth occurs throughout life. Osteoblasts beneath the periosteum secrete bone matrix on external bone, and then osteoclasts remove bone on endosteal surfaces. Usually there's more building than breaking down, so this allows us to build a thicker, stronger bone, but it's not a bone that's too heavy because we keep it hollow. Interstitial growth, we have the cartilage actively dividing here and here on the bone. So we're constantly laying down new bone. We push the epiphysis away from the diaphysis and have this ossify in here. And with bone remodeling, which is the appositional growth, osteoblasts can lay down new bone and osteoclasts can take away bone so that we keep reshaping the bone, keeping it hollow. We can make it wider and stronger, but not heavier. Bone growth is regulated by a number of hormones. Growth hormone is the most important hormone in stimulating epiphyseal activity in infancy and childhood. Thyroid hormones modulate the activity of growth hormone. This is your metabolism hormone. If you can't make energy, you can't grow. This helps ensure that bones grow in proper proportions. Testosterone in males and estrogen in females at puberty promote an adolescent growth spurt. That is, the epiphyseal cartilage divides rapidly, and then it ends growth by inducing epiphyseal plate closure. So we grow the cartilage very quickly, and then we very quickly ossify. If we have excesses or deficits of any of these hormones, we can have abnormal skeletal growth. Bones are constantly changing. We recycle 5 to 7% of our bone mass each week. Spongy bone is replaced every 3 to 4 years, and compact bone is replaced about every 10 years. In older individuals, bone becomes more brittle. The calcium salts first of all crystallize, so they're no longer quite as flexible as they used to be. Also, osteoclast activity begins to outstrip osteoblast activity, so the bones thin. This means that they break more easily. Bone homeostasis is the result of bone remodeling and bone repair. Bone remodeling occurs because we have bone deposition and bone resorption. With bone deposition, the osteoblasts secrete osteoid, and then hormones add calcium and other minerals to form the matrix. With bone resorption, osteoclasts dissolve the matrix. Here we resorb the calcium and the phosphate into the blood. There are two reasons that remodeling occur. One is calcium blood levels. This tells us when we're going to remodel, and the other is gravitational pull. This tells us where we're going to remodel. Bone remodeling based on calcium blood levels is under hormonal control. When blood levels of calcium are low, parathyroid hormone is released, and that stimulates osteoclasts to break down bone so that we release calcium into the blood. If there are high levels of blood calcium, calcitonin stimulates osteoblasts to secrete osteoid and deposit calcium into the bone. Calcium is required for normal nerve and muscle functioning and for blood clotting, as well as for secretion by certain cells. If there is too much calcium in the blood, hypercalcemia, heart arrhythmias, and coma can result. Hypocalcemia causes hyperexcitability of nervous tissue and muscle tissues, so that spasms occur and seizures can occur. The results of mechanical stressors on bone remodeling follow Wolff's law. Bones grow or remodel in response to demands placed on it. This explains a number of things. Whenever we look at a skeleton, we can tell whether it was right-handed or left-handed because the bones on the dominant side are thicker and stronger in the upper limb. They will have more prominent bone markings. Curved bones tend to be thickest where they're most likely to buckle. In lab, look at the ribs and see where the ribs are the thickest. Trabeculae in the spongy bone will form trusses along lines of stress. Large bony projections occur where there is heavy, active muscle attachment. So if muscles are very active on, say, the thigh bones, there'll be very prominent muscle attachment sites on the thigh bones. The bones of the fetus and the bones of the bedridden have very few bone markings because there's not much stress put on them, so there is no need to have the heavier markings. Bones are capable of repair. Fractures are breaks in the bone. In youth, most of these result from trauma, but in old age, most of the breaks result from weakness of the bone due to thinning of the bone. We can classify fractures several ways. One is by the position of the bone ends. In a non-displaced fracture, the bones are in their normal position. In a displaced fracture, the ends are out of alignment. We can classify based on the completeness of the break. A complete break occurs when the bone is broken all the way through. A bone not broken all the way through would have an incomplete break. Fractures can be classified based on their orientation relative to the long axis. Linear fractures would go parallel to the long axis. Transverse fractures are perpendicular. When you think of a broken bone, you usually think of a transverse fracture. And then, do the ends of the bones penetrate the skin or not? An open or compound fracture, the bones are pushed through the skin. In a closed or simple fracture, the bones have not penetrated the skin. So here you see a displaced fracture. You can see how the bones are out of alignment. And here you see a couple of open or compound fractures. There you see the ends of the bone. Here you see the ends of the bone. These are the x-rays on those. A transverse fracture across, and a linear fracture, this little crack right here is the linear fracture in this bone. We say that a fracture is comminuted if the bone is in 3 or 4 large fragments. A compression fraction occurs if the bone is crushed. We usually see compression fractures in the vertebra of people with osteoporosis. Just the weight of the body crushes the vertebra. A depressed fracture is when the bone is pressed inward. These we usually see on the skull. Some sort of blow to the head pushes the bone inward. An epiphyseal fracture separates the bones at the epiphyseal plate. This would occur only in a growing child. They would be the only one that would have a cartilage epiphyseal plate. There's always the danger here that the damage to the bone will cause the bone not to continue growing properly. A spiral fracture is when there's a twisting kind of break. Skiers frequently get this because when they go down with their skis, one leg goes one way and one goes the other way, and that tends to twist the bone. However, spiral fractures seen in children is a red flag for child abuse. Children who have their arms twisted behind their backs sometimes have spiral fractures of their arm bones. A greenstick fracture also can be seen in a child. This is an incomplete break. Think about taking a branch that's full of sap and trying to break it. You don't break it all the way through. Bones can do this as long as they're fairly young bones. So this is a comminuted fracture. You've got 3 or 4 fragments. Here is that compression fracture. The vertebra is crushed. Again, just the weight of the body crushed this one. Here is that spiral fracture. This was some sort of twisting trauma to the bone. And the epiphyseal fracture is when the bone separates at the epiphyseal plate. This is a depressed fracture. Notice how the skull is pushed inward. And this is a greenstick fracture. It didn't go all the way across the bone and break, just broke partway across. Fractures are treated first by reduction. We have to realign the broken bone ends. A closed reduction occurs if the physician can manipulate the bones into the correct position. An open reduction is a surgical procedure. Usually pins or wires are used to secure the ends of the bones together. The fracture is then immobilized. Either a cast is used or traction may be used to encourage the healing of the bone. Which is used depends on how severe the break was, what bone was broken, and the age of the patient. Fracture repair occurs in 4 major steps. First of all, when you break the bone, you're going to break a lot of blood vessels, so blood will seep out into the area, and you will get a hematoma or a clot that forms. The clot will then be replaced with fibrocartilage. We have a fibrocartilage callus forming. Fibroblasts, cartilage, and osteogenic cells begin to reconstruct bone. A bony callus replaces the fibrocartilage as osteoblasts and osteoclasts continue to remodel the bone. This is sort of the initial scar tissue. And then there is final bone remodeling that takes the bone and turns it back into either compact bone or spongy bone, whatever it's supposed to be. It will do this in response to the mechanical stresses placed on the bone. The bone patch will be just as strong as the old bone and will look just like the old bone. So we break the bone, blood seeps out, and we get our hematoma that sort of holds the ends of the bone together. The clot is replaced with fibrocartilage, and then we remodel the fibrocartilage to bone, and eventually we turn it back into the original bone, whatever was there before, either spongy bone or compact bone. On X-ray, you'll be able to see the repair point, but there will be no difference in strength in the bone after it's repaired. Osteomalacia is when the bones are poorly mineralized. Osteomalacia literally means soft bones. Here, calcium salts in the matrix are not adequate, so the bone is soft and weak. People with osteomalacia will have pain when they stand and bear weight on their bones. Rickets is the osteomalacia of children. These children will have bowed legs and other bone deformities. The bone ends will be enlarged. As you put weight on these bones, the heads of the bones just sort of spread outward. Also, the bones tend to be abnormally long. The primary cause for this is either a vitamin D deficiency or an insufficient supply of dietary calcium. While calcium goes into the bone, vitamin D is necessary for it to be placed in the bone properly. Rickets used to be fairly common in areas of the world where there wasn't a lot of sunlight, since you need sunlight to make vitamin D, or in areas where the diet was poor and there was very little calcium. But now it's not as common because we put vitamin D in the milk, and most kids get milk like they're supposed to. Here is rickets or osteomalacia with the bowed legs, and notice how the heads of these bones, these epiphyses, are much broader than they should be. Osteoporosis is a group of diseases. Here, bone resorption exceeds bone deposit. Osteoclast activity outpaces osteoblast activity. Primarily, the spongy bone is affected by this, particularly the bones in the spine and the neck of the femur. This means that people have vertebral and hip fractures commonly. Here you see normal spongy bone, and here you see osteoporotic bone. Notice there are literally pores or holes in this bone, making it very weak and very easy to break. Most people with osteoporosis are older and postmenopausal women. About 30% of this population aged 60 to 70 years of age have osteoporosis, and about 70% have osteoporosis by age 80. Men can have it to a lesser degree. Estrogen plays a big role in bone density, so postmenopausal women are particularly at risk because of the loss of estrogen. There are some additional risk factors. A petite body form is one, insufficient exercise to stress bones, a diet poor in calcium and protein. Smoking is a risk factor for osteoporosis, and there are a few hormone-related conditions that lead to osteoporosis. Hyperthyroidism, low blood levels of thyroid-stimulating hormone, and diabetes mellitus. If bones are immobilized for any reason, this increases the risk of osteoporosis. Males with prostate cancer who are taking androgen-suppressing drugs are also at risk for osteoporosis. The traditional treatments for osteoporosis have been calcium and magnesium supplements, vitamin D supplements, weight-bearing exercise, and hormone replacement therapy to replace estrogen. This will slow bone loss but does not reverse it, and the use of hormone replacement to treat osteoporosis is controversial because estrogen is linked to an increased risk of heart attack, stroke, and breast cancer. Some of the newer treatments include biphosphonates. These decrease osteoclast activity and number and partially reverse osteoporosis in the spine. Using selective estrogen receptor modulators mimics estrogen without targeting breast or uterine tissue. And statins, which are supposed to be used to lower cholesterol, turns out they have the side effect of increasing bone mineral density. To help prevent osteoporosis, you need to make sure that there is a diet rich in calcium in early adulthood. You need to reduce carbonated beverage and alcohol consumption because both of these leach minerals from the bone. That decreases bone density. And use plenty of weight-bearing exercise. This will increase bone mass above normal and act as a buffer against age-related bone loss. Another bone disease is Paget's disease. Here, bone is replaced oddly. There is excessive bone deposits in some places, and it's just haphazard. This is bone replacement and resorption not based on any kind of stress or any kind of need for calcium. Because bone is made very fast, it's made very poorly, and it's called Pagetic bone. There's a very high ratio of spongy bone to compact bone, and there's a reduced mineralization of all bone. This means that you have very thick places in some bones and very thin places in other bones. As a result, the bones break easily. We rarely see Paget's disease before the age of 40. The cause is unknown. It may be genetic. It's possibly viral. Treatment includes calcitonin to help deposit calcium in the bones and bisphosphonates, the same things that are used to treat osteoporosis. Here you see an x-ray of normal bone and Pagetic bone. Notice how you've got these odd thin places here. Notice how it's thicker in some places. Here the bone is fairly uniform, but this odd thin and thickness makes the bones very fragile and makes them break in odd places.